You are.
Okay, right, so like mentioned before, the reason why I've chosen this talk on neurofibromatosis 1 is because we've had 2 patients recently come into the ward, and I just thought it would be useful to have a sort of refresher from the clinicals. So it's only half an hour, so we will just hopefully revise sort of a key few sort of points about NF1, so hopefully remember a little bit about the genetics and the underlying pathophysiology. We'll be able to recognise, which I'm sure you all can, the dermatological manifestations, recall some of the other systems which are involved in NF1, how we diagnose it, so talk briefly about middle aortic syndrome, and then have a sort of framework for how we would assess if we were to see someone in the DGH, and things that we should be always having in the back of our mind if we do see someone with NF1 in A&E. So, what is NF1? Well, it's a neurocutaneous disorder. It's very common, so it affects about 1 in 3,000 people, and it's autosomal dominant inherited. 50% is inherited, and the other 50% is because of mutations. In terms of people who are affected, there is wide sort of variability in terms of the penetrance. So people will be affected in terms of different severities, depending on how much, just based on them, without really any sort of underlying reason. Most people will display sort of features of NF1 by 20 years old, and different features will obviously be sort of evident, will occur earlier in life than later, and I've got a slide at the end which will sort of explain that. So it occurs because of a mutation on the gene NF1, which is located on chromosome 17q11.2, and it's because of a mutation of neurofibromin, whose normal function acts as a tumour suppressor gene. So obviously, when this mutation occurs, there is increased risk of sort of benign and malignant tumours and sort of overgrowth. So really, it's just loss of this regulation, which is what happens. If anyone has any questions, then chip in, and I will be asking you some questions during the talk, so to check you're awake. Right, oh my, this has not turned out very well. Do we know what this is? Yeah.
It looks like one of the cafe au lait, or 2, 3 possibly cafe au lait spots.
Okay, so is it normal to have cafe au lait spots?
Yes, I have them.
Yeah. How many is normal?
Less than 6.
Right. We can learn something today, which is good. So, 10% of the population will have 1 to 2. So that's normal. Anyone who has 3 to 5 needs to have follow-up. And that may well be that they might develop other features of NF1, they may develop more sort of cafe au lait, and also they may have could be NF2, which is less likely to have cafe au lait spots, and they might have sort of mosaic or segmental NF1, which is where the mutation occurred after conception, and people might have sort of NF1 features sort of in one particular segment of the body, so it's a more milder form of NF1. So essentially, the learning point which I got is anything over 2, we should sort of have it in the back of our mind that they need referral to have follow-up. So moving on. And axillary tracking. Okay, brilliant. That's got anything more to say? Got it there. Yeah. And then the other sort of manifestation which we see all the time, which is the neurofibromas. So there are 3 different types. Is anyone an expert? Know the 3 different types of neurofibromas? Yeah.
Brachial plexus. So that counts as a separate type, brachial plexus?
No. Yeah, sort of. Yeah, those are the more sort of complex ones. So there's these subcutaneous, cutaneous, and plexiform. So these are the cutaneous ones, so they're sort of on top of the skin. And then the subcutaneous ones, you might just feel like a little sort of lump just underneath the skin. And then obviously the plexiform ones are the ones which are much deeper, much more complex, like you said, which kind of involve plexi. And these are the ones which are more serious, and I'll show you a picture of those in a minute. And so the key thing is these neurofibromas occur So it's a benign tumour which arises from the peripheral nerve sheath which surrounds the nerve. So, you know, the one which helps the conduction pathway when the signal's transmitted, and it's because of that that we get these neurofibromas occur. And most people will present with these at sort of their late teens or early 20s, and they don't undergo malignant change. And I suppose the only sort of bad thing about them is they can sort of catch on clothing or cause itching, and obviously the psychological facts of having them, but they're not usually removed unless they are causing a problem, because they tend to recur. Okay. And so this is a plexiform neurofibroma, and obviously because it's deeper, and this one is different because it's a diffuse growth which occurs along the nerve length, and it can involve many branches, like you said, and occur at sort of brachial plexi and different plexi. And with this one, you would tend to sort of just see a large area of pigmentation, and then underlying it, you're not going to feel anything, but you would know that there is highly likely to be this plexiform neurofibroma. And these obviously are very difficult to deal with because they are so large and they can sort of invade and, you know, attach themselves. And I guess because of their size, these are probably the more difficult to manage. And there have been trials in terms of using sort of immunosuppressants such as sirolimus, which is an anti-proliferative agent, which they've been trying to trial. Some papers have been seeing that it is successful in children, and some say it's not. But this is sort of one of the sort of instances where they are sort of doing trials to see whether this sirolimus can be useful for this, because they're very difficult to remove. But obviously in some instances it would be necessary. Next, English nodules, which is seen under slit lamp examination, which these are pigmented hamartosis nodular aggregates which occur from the iris. It's a bit of a mouthful, but they're sort of one of the key features of NF1. And then next, can anyone spot? Oh, I've already given you away the answer at the top, so we can all see there's something in the back of the eye there. Okay. And this is the most predominant tumour type which occurs in NF1, usually gliomas occurring in the optic pathway. And this is why children under 7 years old have to have yearly fundoscopy and assessment of visual acuity. It's because of these occurring, and because children often under this age and younger, they won't really, say I've got a problem. So they need to be.
So is that why it's only under 7? Is it because of that? Or, do you know?
I think that's what the guidelines said. I mean, I think everyone needs sort of yearly follow-up, but I would say maybe because of them being unlikely to say, so I have to look that up.
Okay, that's
so skeletal features, I'm sure we can see something is going on there. Yeah, so there's bowing of long bones, especially in the tibias. This will sort of be apparent in children from about a few months old, and this is due to an intrinsic defect in bone formations. Sort of the key features, and then obviously there's loads of other systems which can be involved. So from the cardiovascular vascular side, hypertension, congenital heart disease, particularly pulmonary stenosis. There's a syndrome which can be Watson syndrome, which is associated with NF1, which has pulmonary stenosis, and they look a bit sort of Noonan's-like, but with the cutaneous features of NF1. You can have aneurysms, stenoses of vessels, renal artery stenosis, middle aortic syndrome, pheochromocytoma. About 1 to 2% get hypertension of varying causes. Gastrointestinal stromal tumours, which can cause flushing, and then obviously having a neurofibroma in the gut can cause these kids to have symptoms which we can sort of dismiss as being, a bit of constipation. So something that we could see and think, oh, they're just constipated, could actually be quite significant in these children, because they can cause constipation, a little bit of bloating, indigestion. These children also can have epilepsy, aqueductal stenosis, congenitally. The tumours can sometimes evolve and become malignant. ADHD, autism, behavioural problems, dyspraxia, learning difficulties, and then also malignancies can occur, such as leukemia as well, and also scoliosis is another orthopaedic feature. So moving on, this is very brief. So middle aortic syndrome, the simple way in which I look at it is basically coarctation of the lower part of the aorta. And so you get the same sort of features where you've got the blood pressure gradient where it's higher in the upper limbs and then lower in the lower limbs. And this occurs because of proliferation of the intima, and I'll show you a picture. And then obviously in the smaller renal vessels, it can occur the hypertension because of dysplasia of the small vessels. So here we can see this intimal thickening, and that's what's causing the hypertension in the larger vessels. And then we can see here on angioplasty that there's a narrowing of the aorta, and then down here we've got sort of very narrow renal artery and then an aneurysm. And then we can see here where they've had a graft put in to help overcome the stenosis. So, moving on, it is a clinical diagnosis. Genetic testing is not done routinely unless it's sort of an unclear case of NF1. Imaging is not done for diagnosis either. So even though we know that they're at high risk of getting tumours, etc., we don't do CT, chest, MRI brain. It's very much investigations are led by symptoms, and it's a clinical diagnosis. So the diagnosis, you'd have 6 capillae macules, can be more than 5 millimetres if you're prefertile, and over 15 if you're approaching being an adult. Neurofibromas, freckling, the axillary or inguinal regions, optic glomerula, Lisch nodules, distinctive bony lesion, and first degree relative. So hopefully in the order that we covered things, so that now it can make it a little bit easier to remember the sort of diagnostic features. So 2 of these. So if you have a parent, then you only need to have really 1. And 95% of children who have 6 macules, they will go on to develop NF1. So if we see, he's got this kid in clinic who has NF1, what kind of things are we going to be looking for now that we know everything that we've spoken about?
You confirm the diagnosis, or is he?
Yeah. We know the diagnosis. What kind of things are we going to be doing when we see them in clinic?
Check blood pressure.
That's tick, but 1 is it?
We'll examine him for sort of more emerging cutaneous features like neurofibromas or capillaries.
Yeah, that's 2, yeah.
Check growth of any limb length discrepancies.
Yep, we've got that on there.
Look at the eyes, do ophthalmology, or make sure they've had ophthalmology follow up annually.
Yep.
I feel like we're going round.
Yeah, okay. Was that enough? So basically, everything. So we need to know, like you said there, height, weight, head circumference. Is it getting bigger? You know, is there something growing in there? Is this aqueduct stenosis becoming more sort of noticeable now and causing hydrocephalus? Their blood pressure? Have they got a phyochromatocytoma? Have they got renal artery stenosis or middle aortic syndrome? Examine their skin, you know, to see if any of them are bothering them, or has there been a sudden change in one of their neurofibromas or their plexiform? Because a sudden change can be suggesting that there's a sort of malignant change. They need a developmental examination because they're at high risk of having sort of developmental delay, learning difficulties, etc. Cardiovascular examination, like we said, sort of going with the blood pressure as part of that. Fundoscopy, visual acuity, neurological examination, and these tumours can occur sort of anywhere, so they could cause spinal cord compression, and centrally, peripherally, peripheral tumours, evaluation of the spine, so risk of scoliosis, and they can have delayed puberty. So there's a lot to look out for, and a lot of it is symptom-led. And if you have any suspicions or change, you know, one of these children are complaining of headache, never ever complained of headache before, then that is an indication for doing imaging, or tummy pain. So any change. So like I said before, there is a wide sort of, you know, there's a variety in when these sort of features will present. So when we see them when they're born as a neonate, they're more likely to have these features, which is the café-au-lait macules. I forgot what this stands for, I think it's malignant child.
Juvenile
Yeah.
myelocystic leukemia.
Yeah, that's it. The flexible neurofibromas, they might just have the skin stain, the optic gliomas, and the tibial bone. So this is more likely to present and have onset here. And then in later sort of childhood, like we said, you're more likely to develop the neurofibromas. And then you might sort of start to notice that at this sort of stage that they've got some developmental delay. And the differential, I'm not going to go too much into differentials because I find that people cover too much. I just, in one ear, out one ear, it's too much to take on. But my basic stance of why is it different from NF2 is NF2 has fewer café-au-lait spots and more tumours, CNS tumours. And that's my sort of simple way of saying what the, of trying to remember what the difference is between the two of them. So it's also a lot more rarer NF1, NF2, which is 1 in 25,000. So you're more likely to see a kid with NF1. Yeah, so hopefully we have refreshed our knowledge of what NF1 is and the systems affected. We can recognise the cutaneous manifestations and know when we need to refer for someone to be followed up by a paediatrician, and sort of gone over the clinical diagnostic features and hopefully know what to look out for if we see a kid with NF1 and when we need to take action. And that's it. It's that's it.
Thank you very much.
Thank you. Thank you.
I'm by no means an expert. Yeah.
Do I stop for you? Stop.
Yeah.